yet. And you are now live.
This is Dr. Jamie Koufman. Welcome to the Reflux Hour. It's a half hour. And as you know, I'm looking for ways to reach as many people as possible. I am looking at the statistics for how many people view the post and what happens after the meeting, if you will, is over. And if the numbers stay the same over time, then I'm probably going to move to once a month, especially since a lot of the material is redundant. Today's topic is about doctors, and I'm also going to spend some time answering more questions than usual since I've received so many questions. My website, jamiekoufman.com, contact. It's not up yet. It's going to have Facebook Live questions, so you could click to that, and then it would go to my producer, and she would send me a sheet of questions like I've collected today. So I've evolved like a long-necked Galapagos turtle. In other words, in isolation, those turtles develop very, very long necks so they could reach the foliage that they most wanted to eat. And that took a long time. So I've spent a long time, 50 years, studying respiratory reflux, or LPR. And so let's talk about doctors for a minute. I did a consult with a patient in New York who saw one of the most famous GI doctors in America, who I know very well. We're not exactly friends. And the patient hated him, said he was yelling at him and didn't want him to come back. The patient had LPR and didn't have the GI criteria for reflux. And this very famous, I've been around now, in fact, I worked with him in the 80s. It no longer recognizes laryngopharyngeal reflux. And for those of you who have listened before, laryngopharyngeal reflux, or reflux into the throat, is a mouthful. So since 2017, I've called this respiratory reflux. And that means once you have reflux here, it's in the respiratory system. So LPR is respiratory reflux. GERD is esophageal reflux, and GERD is associated with heartburn, indigestion, and people with respiratory reflux can have heartburn and indigestion, but 4 out of 5 of them say, I never had heartburn a day in my life. Only about 7% of people with respiratory reflux have GI symptoms. So what does that mean? It means that the gastroenterologists don't have any tests for respiratory reflux, and the data are coming in that suggests for every person who has heartburn, believe it or not, there are 4 people who have respiratory reflux. And that means that there's 85 or 100 million people who have respiratory reflux, or LPR. And so your gastroenterologist, including your famous gastroenterologist, doesn't want to see you, doesn't know what to do with you. They'll get some tests, you'll get some big bills, and then they'll basically say, take an Nexium. So there's a problem. The GI's hijacked reflux. So one of the questions I got here, I remember you saying, if you have respiratory reflux, talking to a gastro, this is Martin, is like talking to a tree. But what do you do when all the ENTs tell you to go to a gastro? And that's the problem. So in this talk about doctors, I'm going to tell you that you're better off seeing an ENT than a GI. But the problem is that ENTs don't really have reflux in their curriculum. I've lectured everywhere. Going on the website, on the About, on my bio, at the bottom of my bio, I want you to scroll through the talks that I've given, and you'll see that I've tried to influence. I mean, I've been Harvard, Hopkins, everywhere you could possibly, Mayo, UCLA, all over Europe, and I've been lecturing about these topics in the same way now for 25 years. The problem is doctors make money doing procedures that pay. And one of the problems is that nobody's doing good reflux testing. And the reason is Medicare doesn't reimburse enough. So the disposable, the pH catheter. And so nobody's doing reflux testing. The gastroenterologist is the go-to doc that doesn't know anything about LPR. And at least 2/3 of you have LPR. So I'm going to tell you what I tell my consults. People do consultations with me. And there have been a lot of questions about the consultations, so let me tell you. I never wanted to leave New York. I never wanted to retire. I used to tell my patients I'll stop seeing patients when I'm dead. But I did, and COVID did me in. And so people have asked about the consultations. They're virtual consultations. There's a form that you fill out that essentially gives me 90% of the information I need. And then that profile will give me enough information to say, yes, I think this is a 95% respiratory reflux problem. And then some educational points and some resources. And then finally some specifics of things you can do. People have asked these questions. So I don't do email. I'm not going to do a pre-consultation email. The most common one I get is, how much does it cost? I think it's $4.95 for a half hour. I'm sorry about that, but that's the best I can do. You can't file insurance for this. I don't create any medical record. I do not establish a doctor-patient relationship with you. I have you eyeball to eyeball for 30 minutes. And there's no follow-up email conversations. The best we can do is to start answering these questions that come through on Facebook. So the biggest problem is that, and by the way, how big is respiratory reflux? I'm going to tell you what I believe, and this is going to shock you. 4 out of 5 people with asthma don't have asthma. They have reflux. If you have trouble breathing in, it's not asthma. Second, even if you do have asthma, 70 to 90% of asthma attacks are triggered by reflux. Real asthma, we have trouble with exhalation. Snoring and sleep apnea is about 90% long-standing, silent, nocturnal, nighttime reflux. A lot of sinus disease, nasal disease, ear-popping disease, chronic cough. I've written a book called The Chronic Cough Enigma. I should show it to you, all the languages that it's been translated into, because there's no content like it. I have articles on chronic cough on my blog. I've also added all posts where you can sort of look alphabetically and say, ooh, there's one on Barrett's, there's one on alkaline water, there's one on how to get rid of pepsin. So those articles, whether they're new or old, they're still, I consider, important articles, and the state of the art hasn't changed since they were written a year ago. So what I tell my consultation patients is, I'm going to give you these resources. I'm going to have a conversation with you about your situation, and then you're going to go to the blog. And for those of you especially interested on YouTube, I think I've told you this before. The June before COVID, I gave the keynote speech at an event at the Boston University School of Medicine. And it's on YouTube, so if you go Koufman, YouTube, Kouf, the new field of integrated air digestive medicine. And what it suggests is that we ought to be training primary care physicians to do what I do, which is basically I can determine whether you've got allergies, reflux, asthma, all of those things. So I am otolaryngologist, gastroenterologist. So we can train primary care physicians to do that, and then get specialists when needed. And guess what happens? You save $1 trillion and you get people well. So all you people with sinus disease who had 4 sinus surgeries for postnasal drip and sinus, you should never have had that. I put up a post, if you're interested, this week. How do I know if I have a good doctor? And at the bottom of that post, I mention, and I'm going to go in and add this sentence, but I mention a bunch of surgeries that are overdone, including turbinate reduction, nasal septal surgery, sinus surgery, uveal palatal pharyngoplasty, and all these. The reason why all these problems are created by reflux, big uvula. If you can stop the reflux, that's terrible when things down in your voice box. The uvula gets so big. Big uvula can be fixed in 3 weeks, 2 weeks, if you can stop the reflux. So the doctor discussion becomes ENTs for respiratory reflux. But even so, the ENTs tend to fall into, it's a bimodal distribution. Either everyone has reflux or no one has reflux. And they don't have good reflux testing. The ResTech test, which is available, is not worthwhile. The PEP test, where you spit in a cup, it's my test. Peter decided that he could make some money on it. It doesn't really answer the question either. So you're going to figure out what, take the reflux symptom index. It's on several, I can't remember right now, but it's on one of the last 2 blogs. And if you're reflux symptom, chronic throat clearing, you get a score from 0 to 5. So if you have a high reflux symptom index, you have respiratory reflux. And so you're going to have to basically, suck it up and start educating yourselves. And if you do, within 2 weeks, you're going to know more about reflux than 99% of the physicians in America. Boy, that hurts for me to say that. And you could say to yourself, how could it possibly be? There's this one old doctor, semi-retired in North Carolina, and the rest of the medical establishment. And the answer is, doctors do business plans. And guess what pays? For the GI endoscopy. That's what they do, but that's not how you diagnose reflux. Most people, in fact, more than 85% of people with respiratory reflux have normal esophageal exams. And you read what I have to say about Barrett's. So the answer is that all the treatments that are needed, and neurogenic stuff I'm going to talk about. I'm writing an article for next week on vaguely mediated, the vagus nerve, vaguely mediated neurogenic problems, and they include a cough. It's a dry cough. It includes a burning throat. It's not a reflux symptom, although reflux will make it worse. Vocal fatigue, pain with voice use, and burning tongue, which is another nerve, but it's the same. It's the same issue. It's neurogenic or sick nerve caused. So the answer is you can call a major medical center that has, an ENT department with 12 people, and among those 12 people, they probably have 2 or 3 people who do laryngology. They call themselves laryngologists. That was one of the first full-time academic laryngologists in 1978. I had the 4th laser in the United States. So you want to know, do they have any laryngologists, and do you have anybody? And you need to speak to a nurse person, that someone at the front desk is going to say, listen, I'm coming to see you from 200 miles away. I need to know if you have the resources. So you want to know that you have somebody in ENT who knows about reflux, and the way they'll know about reflux is, do they do transnasal esophagoscopy, which is not going to be the topic of today's discussion. And so you're looking for an ENT laryngologist who knows about reflux. In general, the ones that have fellowships in Boston and Vanderbilt don't know much, because that was a group that didn't believe in reflux, because they still relied on the GI and the GI test. And so most of the ENTs who are laryngologists have fellowship trained. I had the first fellowship in, I don't remember, I think it was in the 80s in laryngology. So the doctor question, I need to finish, and then I want to spend some time discussing questions today because there are so many. One of the things in the article, for those of you who didn't read the article, is if you have an arrogant doctor, leave. Get another doctor. Arrogance, other than being unscrupulous, unethical, or a liar, arrogance is the worst thing you can be. So you have a right to ask and answer questions, including pointed questions. Let's say you're going to have a surgery. You can say, how many of these have you done, if it's a young doctor? And if they say 13, you probably want to find a doctor that's 10 years older that's done 300. The learning curve for a lot of surgical procedures is 200 cases. So you're entitled to ask these questions. And you're entitled to ask probing questions. If I don't have this test, what's going to happen? If I have the test, is it going to change what you're going to do? Are we going to use a different treatment? What are you looking for? If the answer is, oh, we're looking to see if you have cancer, that's bullshit. You don't get a CT. It's a CT MRI question. For every 2.5 people, you get a CT and MRI every year. So think about that. It's a $315 billion a year industry. A lot of places won't even do ordinary films anymore. They don't make money on them. So you say, oh, we don't do plain sinus films. We do CTs. But a CT is $3,000 and insurance pays for it. And if you don't have insurance, you're going to pay $5,000. So overutilization of expensive resources, medicine is business. A business plan is being created. And the reason why the gastroenterologists haven't changed is there are millions of people who have heartburn and esophageal disease, and that's what they do. They stick scopes down and put them on Nexium, and they make good livings doing it. So understand that the thing the specialists do best, and I'm talking about ENT and allergy and pulmonology and GI, the airway, the air digestion, the thing that they do the best, more than anything else. People used to say, oh, diagnosis. No. Treatment. No. They know all about their thing. No. What specialists do best is they make money. That's what they do best. And we need to re-empower primary care physicians. So you have a doctor you know, who you trust, you can educate. Say, I have neurogenic cough. I've talked to Jamie Koufman. I've done a consultation. Here's the book, and I'm sending you to the article and to the YouTube talk, so you can be educated too, and then you can help me with this. So understand that the state of the art on a scale of 1 to 10 is 1. And that when it comes to respiratory reflux, the healthcare system, it's actually better in England because I lectured there so many times. I had a research group there in the UK. But it's bad. We're in the Stone Age. And, and last thing I have to say about that, so I don't run out of time on questions. At any moment in time, we're great. We can sew a hand back on. We can do all these things. But when it comes to common things, which you all have, you run from specialist to specialist to specialist and don't get answers and don't get treatment. So that's what I have to say about doctors. Read the article on doctors, and I'm going to devise a doctor rating system instead of just going 1 to 5 stars. Are they a good communicator? What's the staff like? Did it answer your questions about tests? So understand that a caveat emptor, you need to be wary of the fact that your doctor is your entry point into an industry. I went into medicine, not healthcare industry. I went into medicine to help people. I knew I'd earn a good living, but I went into medicine. The healthcare industry is corporate, and their job is to make money, and they do. And so right now, American medicine is by far the most expensive in the Western world, and by every metric of quality of care, we are the worst. think about it. So there we have it. Now, which doctor do you see? I've answered as best I can. But if you really have respiratory reflux, going to a GI, in my experience, you'd be better off talking to a tree. I like that refrain. So let me answer some questions. I've gotten a lot of them, and you should let me know questions for next week. Next week is going to be pretty much all Q&A. I've got so many, but I'm going to begin. And let me know if you want to mention first names or leave first names out, because if I use a first name that is someone that's like, into a group, and then they'll be identified. But in any case, I'm going to use first names today. Jasmine wants to know why there is a huge low stomach acid versus high stomach acid, in quotes, debate between doctors. What is your stance? There's no such thing as low acid, period. I've done tens of thousands of reflux tests, and the first thing we do to know where to pull back is we, hold on, I have something. First thing we do is go in the stomach. So everyone has acid. Furthermore, let me answer the second question. If you took a handful of any acid suppressive medicine, take 10 Prilosec a day, instead of making a ton of acid, you still make a half a ton of acid. So there's no such thing as not enough acid. Now, if you've had a Billroth 2 and your stomach's been removed, you don't have enough acid. If you have pernicious anemia, you don't have enough acid. So whoever's telling you don't have enough acid, the answer is unmitigated bullshit. This doesn't exist. Now, that gets to the next question. Wondering if Prevacid before meals, Gaviscon after meals, and alkaline water can cause low B12. And so the answer is you can't get pernicious anemia from lowering your acid. Pernicious anemia is an autoimmune disease. So your B12 absorption has nothing to do with any of these medicines. B12 absorption is not affected. That said, women in my age group, and maybe men, I take sublingual. I used to do the drops, but they were red and they get on my clothes once in a while. I take a little sublingual B12 and a D3 and a multivite every day. I also take some magnesium so I don't get constipated, and some calcium for my bones. And those are my supplements. I've written an article on supplements on the blog. You don't want to be on glucosamine, B complex, and so on. So this whole question of absorption is again medical bullshit. Okay, so if you take now you can have side effects from the PPIs. You can have a poor motility. The stomach can stop working. You have abdominal pain. You can have diarrhea or constipation as side effects. So, but none of these medicines in any way interfere with B12 absorption. There's no such thing as not enough acid. So I don't even know how this got started. So that gets me to the question that go with this, about what do you take for it. Digestive enzymes do nothing for anybody. Take that back. They made somebody rich. So not a shred of evidence you should take digestive enzymes, and you certainly don't want to take pepsin or hydrochloric acid. So pepsin is what causes reflux disease everywhere. It's acid activated. Under no circumstances should you be taking an acid for your reflux disease. The only article that appears in the medical literature is esophageal burns with apple cider vinegar. So stay away from acids, stay away from supplements. None of them work. You can take all the DGL you want. You can take, but digestive enzymes, for all intents and purposes, you can throw them away, and you'd probably be better off. Can you please talk about Pepsid? about long-term Pepcid use. So Pepcid is famotidine. If taking 4 times a day before meals and bedtime, that would be double the over-the-counter recommended dose. Is this safe long-term? And it is. Right now we have 2 H2 antagonists, famotidine, Pepcid, and cimetidine, Tagamet. What I recommend is that once a year you switch from one to the other. And the reason is you seem to get a little bump. When we had ranitidine, we used to go ranitidine, and it seems to be beneficial to switch medicine every 6 months or a year. But I've had people say, I did it every 2 years. But you can take them long term. If you read the article on pregnancy, you'll see that there's at least 9 months or a year of this dose. When is it safe to drop PPIs completely? This is Tammy. Some of those have side effects of chronic cough. I don't know what this is about, this question. The same person was into digestive enzymes and pepsin. So the answer is, you don't just drop. You gotta go to my article on PPIs. You go ahead and buy your famotidine and buy your Gaviscon Advance, and then put yourself on a program. All this stuff is on my website. Blog should be read like you were a student going to get a quiz on it tomorrow. It's not a rapid read. Sometimes there's one paragraph that's crucial. So let's get to these are the ones that came in. Will surgery cure LPR, and if so, which type? So the answer is, and the next question is about TIF. If you want to have a TIF, I'll sell you a bridge in New York, okay? The data on TIF is horrendous, although doctors make money. I recall even the 3-month data is crap. So the only procedure that has any benefit is Stretta. There aren't that many people doing it and doing it well. It's a non-invasive surgery. The only surgery that is truly effective for reflux is a laparoscopic fundoplication. Problem is, for people with LPR who don't have heartburn, the surgeons want to do partial wraps. Instead of doing a 360-degree wrap, they want to do a 270. They don't work. So you got to have a surgeon that understands respiratory reflux. Secondly, I rarely recommend surgery. Reflux can be fixed by diet and lifestyle and some of these things we've talked about today. So the last question on this area is, can a hiatus hernia be treated with diet alone? I've written an article on hiatal hernia. Everyone has, or not everybody, virtually everybody who has a barium swallow or an endoscopy has a hiatal hernia and an irregular Z-line. I did thousands of transnasal esophagoscopies, and they're of no clinical consequence. You can have reflux without a hernia and a hernia without reflux. Until you get to well in excess of 4 to 6 centimeters, we don't worry about hiatal hernias ever. In the 50s, people ran and have surgery for their hernias, but that's no longer the case. And now I have a lot of questions, and more than I thought. So I'm going to answer some of the obscure ones. Someone said you make no mention of GERD and the AF link. I don't know what the AF link is, so you can let me know and I'll answer that question next time. Can reflux mimic palpitations? I was seeing a cardiologist. For you, go see the article, the vagus runs the heart. The vagus is what happens when you faint. You went a bradycardia and vasovagal. So we've done studies where we had a patient where the Holter monitor for the heart and the pH for the reflux, and that reflux can be associated with abnormalities of rhythm and so on. Final question, and then I'm going to sign off. Can cricopharyngeal spasm be confused with reflux? The answer is cricopharyngeal spasm is reflux. So there's no other disease, and you should never have surgery for it. So this is Dr. Jamie Koufman signing off. Next week it's going to be mostly questions. So go ahead and submit them through Facebook, and soon we'll make it easier through the website. Thank you all very much.